have the pleasure of introducing our next speaker, well, our next moderator, actually, and that's Eran Bendavid from Stanford. And he's an infectious disease doc and also works in policy and disease modeling. And what I really liked when I pulled up his website was to show you how diverse the themes that he works on is. I'm just going to read to you the title of two of his recent articles. One is Cost Effectiveness of Radiation and Chemotherapy for High-Risk Low-Grade Glioma, and the other one is Armed Conflict and Child Mortality in Africa, a Geospatial Analysis. So it just shows you how incredibly diverse the application of his skill sets. And it's a real pleasure to have him here. Come on up. And in terms of his degrees, he may sound Israeli, but he got his undergraduate degree at Dartmouth. He got his MD from Harvard. He did his residency first at Penn and then at Stanford, and he's been at Stanford ever since. So the way he sounds is a little bit misleading.
Thank you, Steph. Thank you, Jim, for spearheading this and for everybody who's been organizing this. So our next panel is on the NextGen intervention economics. My job as moderator is going to be just to introduce our speakers and really then just to really be really hard on keeping them on time. But I'm just going to try to step out of the way and then moderate the discussion. So our two speakers is Sergio Bautista-Arredondo, who is an experienced health economist, which I think sounds really sort of cool, but in this place, it's like all of us. So an experienced health economist at the Instituto Nacional de Salud Público in Mexico, and also the director of the Research Consortium on HIV and AIDS, and works a lot on policy analysis and on impact evaluations. He'll talk to us about costing studies and thinking about a variety of ways of thinking about costing. And our second speaker is going to be Starley Shade, who works right across the street. She's an epidemiologist and associate professor of epidemiology here at EpiBiostats, as well as the Global Health Sciences, and has worked on a lot of the trials that we've heard, some of them today, SEARCH, and will talk to us about how do you think about costing in the context of these increasingly complicated and maybe not complicated, but unique and flexible ways of doing trials in developing countries. So with this, I'll welcome our two speakers. Thank you.
Thank you, Eran and Jim, for the invitation. I'm very happy to be here. And I'm sorry I changed a little bit the title of my presentation, but I did want to emphasize that I want to talk about moving away from something, and I'll explain why. This is part of the work we've been doing in the Global Health Cost Consortium with many partners. You can see the institutions there that are involved in this work. So I want to start apologizing because I'm going to talk about costs. And for most people, this is a really arid and tedious topic to talk costs. And a very good example of how people think about costs are my good friends, epi-modelers. When they are doing epidemiological modeling to, for example, model the impact of different interventions, they think it's sort of a nice touch to add cost information and then to their modeling exercises, and then they have a cost effectiveness analysis, which sounds really fun. And then they just talk to people like me, and they say, okay, what's the cost of this intervention? Just give me the number, right? It's just one number. What I need from you, please give me the number. Why are you still talking? Just give me the number. And that's, I think, a good reflection of what happens. So what that means is that people tend to think about cost as a quality of the interventions of the programs, something that it's sort of a feature that doesn't change. We just need to know the number, and then we know everything we need to know. Economists tend to see cost differently. They also hate cost, by the way, but they at least they think about them differently. When economists talk about cost, they think about technology, and they think about behavior and decisions. It's sort of a little more complex and nuanced thing. The question I want to address here is whether we can identify and isolate these two sources of variation and make predictions that decision makers and even modelers can use in terms of costs. Okay, so I want to start with this hypothetical problem that I will present to you. Imagine there's a decision maker who needs information on the costs of circumcision for her country, but for very basic reasons, just budgeting, planning, and make those kind of decisions. And the information she has is just one number, one estimation of unit cost for circumcision made in her country a few years back. And that's information, literally one number. And that's the information that she has to work with. And what is the problem with that? I think there's a problem with it. And the problem is uncertainty. And let me explain this a little bit more. To start with the most simple and basic, unit costs assumes that the costs are constant with respect to scale. So if we have scale, so the size of the program, the number of circumcisions performed here in the horizontal axis, and then the cost or the unit cost in the vertical axis, this is what the constant unit cost looks like. It doesn't change irrespective of scale. And so to answer the question, how much will it cost to scale from A to B, the answer is very simple. But in reality, we know that the relationship looks more like this with economies of scale, or typically looks more like this. And so the answer could be very different in the case of this program. It could be even more complex depending on the characteristics or the technology behind these cost curves. But the problem is not only that the unit cost assumes that the costs are constant with respect to scale, but it also assumes that it's constant with respect to everything else. So for example, imagine that's the real curve in rural settings in this hypothetical country, but that in urban settings looks differently. And that even more, in hospitals in urban settings is different. So the technology behind these curves is different. In technology in the sense that the way inputs are transformed into outputs. And it could be, then you can see really complex, the reality. So the question is, can we provide better information in terms of costs for decision makers or for different types of users than the unit cost point estimation, which I think is wrong, and we just don't know how wrong it is. The reason why I think it's wrong is because that number, if we're going to use one number, should reflect the actual distribution of implementation characteristics of this program and the heterogeneity in terms of the technology producing these services. And also levels of scale, because scale usually is very, very important in determining cost, instead of this arbitrary average unit cost, which reflects the sampling strategy used behind whatever study was used to make that estimate. So to address this problem, we use data from 7 VMMC studies, and this is just an example of how we're approaching this, and 8 countries. And we set up to explore the variation in unit costs. And you can see there we have, so we actually called and asked the authors of these studies to share their data with us. And we ended up with 220 facilities of observations. And for anyone who knows about this type of studies, know that this is a pretty large sample size for a costing study, 220 facilities. And you can see the distribution in terms of the characteristics of these facilities, in terms of urbanicity, ownership, and facility type. Okay, and so what I'm going to show you is with this sample, what we did was look for the systematic sources of variation of unit costs in terms of this very specific characteristics of the platforms for service delivery, urban versus rural, government, private, clinics versus hospital, and countries. And then secondly, I'm going to show we're going to use this data to predict costs outside of the sample of these 8 countries. So can we use this to not only explain the variation, but also predict the cost for other places? And this is how the sample looks like. This is the cost versus scale. And it's almost a perfect picture for random, right? Like random correlation. And you would expect to see something, what I showed before, negative correlation. And if you look really, really, really hard, you see there is some negative correlation that's even statistically significant. But as I said, not very informative. So what we did was to analyze this data and see whether we could find systematic associations or relationships between costs and other characteristics. And we used lots of different types of regression modeling techniques. I just want to show that we use, obviously, scale, but also the other characteristics that I mentioned before to explain these relationships. And then using the results from these models, we then went back and predicted the curves in our sample. And then we ended up with this. So this is the same sample. And now each curve here represents the relationship between cost and scale in a very specific scenario, in a very specific combination of country, urbanicity, ownership, and type of facility. And as you can see, a lot of the seemingly random variation that we saw initially can be explained with these 4 characteristics, just the country, the urbanicity, ownership, and the type of facility. And the sample now, or the relationship now, makes a little bit more sense. And you can also see that in this graph when we just distinguish each specific country, the sample of that country, and the variations that we can predict. And in some places we're pretty good in terms of fitness, like South Africa. We explain most of the variation in that country with these models. In other countries like Rwanda, it's not so good. But anyway, that's the first part of the analysis, explaining this variation. And you can see when someone says, give me the number, and if you see the initial graph I presented, you can take your pick. Whatever number you want is going to work for one specific scenario. So now the second part is, can we predict costs for other places? And then we use similar modeling techniques to try to see to predict the relationship between any given country, given the GDP per capita, and the costs of specific services. And we did that, and we validated our predictions. The way you validate predictions is that usually you take out of your sample certain percentage of observations, then you run the model, and then you predict those observations not included in the sample. So that's what we did, but instead of taking just a sample, we took entire countries from the analysis and then predicted the values for those countries. And this is what we found. So we have the observed, or the predicted value in the horizontal axis, and the observed value in the vertical axis, and the closer to the line, the better the prediction is. And you can see by country how we did. 90% of these predictions are not statistically different from the observed value. And if we distinguish by quintile of the costs, we see that we did a lot better in the 2, 3, and 4 quintiles than in the extremes, although there are no significant differences. So going back to the give me the number question, if we take these 4 countries as examples. And we have all the possible delivery platforms that we included in our model. And we looked really hard in the literature for information on the costs of providing circumcision in that specific combination of service delivery platforms. This is all we find from the unit cost repository, which is another product of the consortium, which compiles everything that has been published on costs. And so this is what we can find. For these 4 countries, there is only 4 numbers. Using our models, we can predict all of them. And even for the ones we also have a study, we can validate and see how well our predictions do compared to the literature. And so we can do a little bit more, a little bit better with this type of analysis in predicting not only one number, but a specific number for the characteristics of the programs that are being implemented. So I just finished with this message that I want to leave here with you, is that I think it's important to move away from this notion of just one number per intervention as if it's just one characteristic that never changes. And moving from this single arbitrary estimation of constant unit cost to, which is the current approach in policy, widely used in modeling exercises, and which I think potentially leading to biased results, which ignore the real variation in this, and then instead going for empirical estimates of cost curves and revealing the uncertainty behind. Thank you.
Good afternoon. All right. So I'm going to present information from an ongoing trial that Elvin Gang is actually one of the PIs for in Kenya. And so I think this is a nexus between implementation science and economic analysis, and I am going to talk about costs. So, one of the key issues that we're facing right now in care of people with HIV is trying to make sure, okay, we've spent all this energy getting people on treatment. How do we keep them in treatment for their lifetime? And so really working on sort of what are the best retention strategies. So I'm distracted by you. You could take just a minute. So we've identified 3 sort of relatively inexpensive interventions to try and retain folks in care. Those include text messages to remind them of their appointments, transportation vouchers, money always helps, and peer navigators, which are folks who are also from the community who help, provide social support and also just reminders of that they need to go to care, and then help them navigate the administrative process. However, the cost of these interventions varies pretty substantially. Paying for a person is a lot more expensive than paying for a text message, but the effectiveness of those interventions also varies. So in this particular trial, we're implementing a sort of a newish trial design called a Sequential Multiple Assignment Randomized Trial. It's an acronym in search of a title. And I'm going to talk a little bit about how we did that and how we're doing costing within that. All right, so a SMART trial essentially allows for the testing of multiple adaptive interventions at the same time. And so, so we could do a clinical trial where we say, what's the best intervention that we use when we newly put people on care. And you could do a randomized trial around that. You could also do a randomized trial if looking at folks who fall out of care. Once somebody falls out of care, how should we intensify their efforts? But the reality is that what we really want to know is what should we do overall? What's the best strategy for us to pursue in order to keep the most number of people in care. And so the SMART trial sort of allows us to answer all of those questions simultaneously. Jim asked me to talk a little bit about the SMART trial design, so we're going to do a little veer into implementation science for a minute. So there are 4 key components of a SMART trial. We have to have a sequence of decisions. So in this case, we want to know what we do when somebody's starting treatment, what do we do when somebody falls out of care, and what do we do if somebody doesn't fall out of care. Then you also have to have a set of treatment options at each point. In this case, we have text messages, vouchers, peer navigation, and then standard of care in those settings. We also want the third component of a SMART trial are tailoring variables. We haven't implemented them in this particular context, but they might include whether a person has a cell phone, whether a person, needs money to get to the health facility. Do they live far? Do they live close? And does the person actually have social support? A lot of the literature in this area suggests that men actually do better with peer navigation support than women do because they tend to have less social support for their care. And then finally, we have to have a sequence of decision rules. So basically, what do we do at each point in time? And I'll lay out how each of these plays out in our trial in a minute. All right, and then finally, we have sort of 3 different types of questions that we can ask all at the same time. And we're asking 2 of these in this particular trial. So the main effect questions include sort of what's the best first intervention, what's the best second intervention, and then we have what are called embedded adaptive intervention arms, and those include like the best sequence of the intervention, so what's the best strategy overall. And then finally, things that correspond to like effect modification or as treated analyses are treated as optimization aims. All right, so for this trial, we have 2 main effect aims and then an adaptive intervention aim. And so the first aim is sort of to look at the comparative effectiveness of the first stage interventions, and that is standard of care, or we're calling routine education and counseling, text messages, and transportation vouchers. And so essentially folks got like $1 every time they came to a clinic visit. So the second aim is really looking at that second main effect. So what do we do in the second stage? And for this, we're looking at the standard of care, which is a single outreach exposure. Somebody goes to their home. The second is whether it's an intensification to include SMS plus vouchers or SMS or adding SMS to a voucher. And then the third is a peer navigation. And that's sort of repeated contact with that person over a period of time. And then the third aim is really looking at the joint effectiveness of the best strategy and the cost effectiveness of those. All right. So here's the study design. Now, as you can see, we have 3 interventions at the first stage, then we have 3 interventions at the second stage, and then we have like a stage 2B where if somebody does well, then we're either going to remain on the standard of care or discontinue that and have them be on standard of care. And so we end up with 14 different pathways that somebody could theoretically go through here. And so, the quantitative analysis is challenging, but then the cost effectiveness analysis is really challenging. All right, so for those of you who like words, I'm going to restate this just for that. So the stage 1 is we look at those first 3 interventions. The stage 2, we look at outreach versus SMS plus voucher or navigation. And then stage 2B is for those folks who remain in care for a year, do we continue what they're doing or do we discontinue what they're doing? And that allows us to sort of look at that step-down approach as well. Folks are followed for 2 years to assess engagement in care through a variety of outcomes and viral suppression. And just to step back, so the primary outcomes are sort of total time in care over those 2-year period, but we also look at time to lapse in engagement for that first aim, time to re-engagement for that second aim, and then also viral suppression. Okay, so for costing. So a traditional costing approach would require that we look at the costs of all the folks in each of those 14 different strategies. And Jim actually was the costing investigator on this project when it started, but he was kind enough to retire, so I've taken it over. But, even he couldn't, I don't think, come up with a way to cost all 14 of those different interventions. So we sat down and talked about the best approach to take. And in these, we decided to really think about, like, what are the key components of these various strategies, and what are the pieces that we need to be able to do? And I would love to hear folks' comments on this approach, because we haven't actually written up the results, so I'd like to anticipate any reviewer comments that we might find. But basically, we wanted to cost the specific activities of each of the component interventions. And so that becomes a lot easier because we're only looking at 5 interventions instead of 14. And so for the first stage, the routine education and counseling just includes group education counseling sessions that happen right when somebody gets to the clinic, and then counseling sort of at the end of the session. The SMS includes development of the SMS platform, monitoring of the SMS platform, and then they carry one staff member carries the cell phone to return texts. The vouchers includes sort of disbursement, which is the easy part. That takes like 2 minutes. The hard part is all the documentation that they have to do to manage the funds. Outreach is just a single home visit. That's fairly straightforward. And then navigation includes all the staff time associated with texts and phone calls and home visits, as well as the transportation to those home visits. And then we use all of these observed data to as well as the intervention exposure to estimate the cost for each individual, and then add those all up to get the total cost for each arm. All right. So we use pretty traditional approaches to do this. We did a series of time motion studies with patients. First, we observed them just to understand what are the actual activities that are going on, and then we did time motion studies to say which providers are they seeing, how much time are they spending with each provider, and what activities are they doing with each of those. We do microcosting, so once we have all of this information on how they're spending their time and what they're actually doing in each of these pieces, how much does it actually cost for each of those pieces? We actually went out with folks to the home visits a series of times because we wanted to understand how much are they spending on travel time, how much are they spending on time with the person. And then finally we did staff time studies to assess indirect costs and activities outside of patient contact. And that's actually a fairly difficult area. All right. We've talked quite a bit about DALIs here. I wasn't sure how much folks knew or wanted to talk about those, but essentially, as folks have described, it's a combination of mortality and health status. And so for this study, we're using information that we've observed on folks' health status, including opportunistic infection, CD4 count, viral load, whether or not they're on treatment, whether they fall out of care, as well as information from the literature on things like CD4 cell decline, as well as expected mortality at each stage. And then this information will be used to compare the cost effectiveness of each of the different strategies. All right, just one equation. That's all I got. And so in this case, we just line up all the costs of the intervention. This is just sort of a how-to for those of you who don't have a strong background in cost-effectiveness analyses. We arrange them by cost. We compare the different costs between adjacent strategies, the difference in effectiveness between those strategies, and then we divide by those two. So this is sort of the equation I got from Jim when I first learned how to do this work. All right, and then the results of this study will be used to identify the strategy or sets of strategies that are most cost effective in keeping patients in care. And so, we felt like it was important to look at this study because adaptive trial designs can really set us up for really thinking about resource allocation. So like with a fixed budget, which strategy or strategies will get us the best outcome? Given the current level of investment, how much would a program need to invest in order to meet a specific target? And then how much incremental improvement would we expect for what incremental costs? So that's it for me. Thanks.
So I'm going to ask Sergio and Starley to come up. How practical is it to really do, collect so much dimensions of variation on costing? But because I want to make this more interesting, and because Stefano spilled the beans that I do work on armed conflict, I'm going to set it up as a conflict between the two of you. Do you agree with Sergio that unit costs really is the wrong way to think about costs? And then Sergio, you've seen they collect mostly unit costs for a lot of these various interventions. How do you think that they should think about unit cost collection in the context of a trial that's already so complex that you barely can get, just the costs of these particular interventions? So, for both of you.
No, you go.
No, I completely agree with you. We did a study of the cost of rollout of an EMR in Kenya. And it was implemented in like 200 different health facilities. And we found that among health facilities that had fewer than 700 patients, the incremental costs were pretty astronomical. They were upwards of $600 per person per year to implement, in a tiny health facility. But for, basically the curve was just extreme. And for those that were over 700, it was less than $20 per patient. Mm-hmm. And it varied really substantially by whether it was a big health facility or a small health facility or one that was in a city or not. And so, while I recognize that modelers really want that one, I get that too, right? What do I use on the numerator?
Right.
That, sometimes there's pressure actually on us to diminish the amount of time that we spend talking about costs. That it is really about cost effectiveness and those costs per DALY. And so, I'm definitely in concurrence that having more information about how costs vary is really important, particularly for resource allocation.
So there's no conflict, I think. No, and I don't think we're arguing that we need to collect a lot of data. I just show the variation associated with three characteristics, like pretty basic, that I think most costing studies, they already have that information. The type of facility, whether it's urban or rural, and ownership, and those explains a lot of the variation. I didn't go into the real complexity of. So basically, I talk about technology. I didn't talk about behavior, which is then I think it is much more complex. If we look at the variation in costs across settings, and we're able to explain some of the variation with those characteristics, but then there's more variation that we cannot explain with that. And that's probably related to decisions made at the facilities, to how people run programs in a very specific place. And in order to understand that, then we will have to collect data on decisions made by management, staff in the facilities. I didn't go there. I'm not asking for that yet. But I think those basic implementation characteristics, I don't think that's a lot to ask. And our results show that they do explain a lot. So I think it's worthwhile. There's a sampling size issue, of course, but I won't go into that.
Yeah. So that's so that leads me to another related question is that it makes sense if you're trying to get an estimate of the overall budget impact to really get a sense of the variation in the cost. But the question is for a cost effectiveness analysis, or if you're trying to decide whether a particular intervention you should recommend it for adoption. Do you have examples of when using the unit cost has led to the wrong decision? So if you're using some kind of variation, does it actually lead you to adopt or to think about different decisions that might actually be adopted? Related to that is the fact that not only does the cost potentially has elements of variation, but the effectiveness. You can have heterogeneous treatment effects, and so in that sense, how do you sort of think about the need to make a singular recommendation versus all of these various levels of diversity?
Yeah, so I think for answering some questions, just one number is all you need. And the point of or one of the points I was trying to make is that that's fine if that's the right average, if that's the right number. But what if we don't really know how far we are from the real or the right average? I don't think the problem is using one number. The problem, I think, is how uncertain are we that we're using the right number. We don't have examples of it. That's something we're working on with this data. Yeah.
Great presentations. Thank you. I want to further pursue this question of the link between the two topics. Starley, you mentioned that rather than analyze 14 integral pathways, you've reduced it to 5 elements that create those pathways, if I can summarize it that way. Sergio's demonstrated the value of multiple data points. Is it fair to say that you could take those 5 elements and study them elsewhere, even if not in the context of an a smart trial rather, and be able to then construct a plausible variation on each of those 5 elements so that Sergio could figure out how to analyze it and come up with projections for other settings?
Well, the piece that I didn't talk about very much is the fact that we are using the information on the observed sort of utilization of those interventions for each person in the trial to inform the overall cost. And so, for instance, it's possible that starting out with an SMS and then going to a peer navigation is different than starting out with standard of care and then going to a patient navigation. And so you might actually have fewer opportunities to engage with patient navigation if you had a more intensive intervention initially. And so I think, it would be an incomplete picture if you tried to explore those outside of the adaptive trial, because you wouldn't get the additional sort of benefits of the trade-offs that happen or the advantages of having done a more intensive intervention initially.
But I would say making the effort of collecting the data as they're doing the trial, it's already an improvement. That's better than what happens most of the time, which is ignoring that part, just doing the effectiveness side and then asking for a number.
Go ahead.
I want to ask you about the cost database. When you showed those regressions, you can find significant relationship, but also you can look at that and go, there's a lot of sort of variability still in there. Is there any thought about using that database to target the next study that would give you the most information about the places where you feel like the model is weakest, or you have sort of the biggest opportunity to gain information about how you can extrapolate better?
The next study, the next costing study, you mean?
Yeah, so Bill and Melinda Gates Foundation calls you up and says, if we could run the next 10 costing studies, where should we do them to get the most out of what we learn? Is there a thought about how you would approach that, or what you might be able to do?
Well, we have been thinking about this a lot. Which characteristics, which variables should we use to explain the variation? And more importantly, I think once we understand the sources of variation of costs, we can then study which are justifiable reasons, right? Like the reasons I showed. But then there could also be inefficiencies. There could be some variation that is just linked to waste or to poor decisions in managing programs. And it would be really interesting to understand those, the extent to which those characteristics influence cost variation, and then further, if we can identify those, can we reduce those wastes, those inefficiencies, that waste? Can we develop interventions once we understand that reduce inefficiencies in the implementation of programs? So I think there's a change there of things that we could learn from these types of studies, and we're trying to convince people, but this is where we are so far.
I have one more question for Starley. So when that's on your topic of calculating the indirect costs, we're trying to estimate the indirect costs. A lot of the interventions are a package, and so you can sort of get the incremental or the marginal cost, but the indirect costs are not so discrete. And so trying to think about how you think about those in the context of really trying to get a very sort of almost like just a small sort of incremental cost when you don't measure the baseline. The other thing that's related to that, again, sort of tying to some of the issues that we talked about earlier, is that a lot of the things that we talk about in terms of financial protection or cognitive benefits or labor benefits are potentially some of these indirect costs or the indirect benefits or monetary benefits. And so how do you think about those in the context of a discrete trial that really only has so very well-defined endpoints?
So I don't think the issues in estimating indirect costs in this context are really different than they would be if you had a multi-arm trial. You're always going to have those components of the intervention that are outside of the direct service, and so those include things like trainings and meetings and transportation and operational costs, and that's why we have sensitivity analyses. We basically, you take a particular approach as your base case, which likely will have to do with the proportional costs of each intervention, and then you vary from that. So, what does it look like if we modify it so that it's allocated equally? What does it look like under different scenarios that make sense? And how do we vary that? I mean, I'm sure that there are other folks who've thought far more than I have about how you allocate indirect costs in the context of multiple interventions simultaneously. But, that's certainly a challenge in everything that we do is how do you measure those costs, and which costs do you actually include? Do you include just the costs that happen in Kenya? Do you also include the costs of the investigators here at UC? Right? And if you include their travel costs to the country, you're in trouble.
I'd like to thank Sergio and Starley for interesting discussion, for bringing some of these issues to the front.